Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Delighted to be back with you on, yes, a rainy Wednesday morning, but we are happy to be here. Broadcasting live from the Dolph Simons Family Studio. We have an amazing program this morning. Now, I know I say that every day, and I am horribly biased about this program, but today is really special. You all have heard about the opioid and the addiction crisis that has really ravaged America, ravaged the world. And today we have really great guests who are going to speak with us about that. Roopa Sethi is our Addiction Clinic Medical Director. Roopa, welcome to our program this morning. In Studio B is Cyndi Brooks, our Addiction Clinic Nurse Manager. And joining us virtually is Dr. Ann Manzardo, the Associate Professor at KU. They all have data to share about opioid addiction and the impact COVID-19 is having on addiction. And we know that it is alcoholism, addiction, and things. And when people are isolated, depressed, sometimes addiction is a place people have been ravaged by as well. But first, Hawk, how are we doing on the numbers today?
We're good. You know, I'm looking forward to the show. We know the crisis and how much devastation the opioid issue has caused prior to the pandemic, and we know what the pandemic has done for exaggerating and making further problems worse. So this is certainly one of those topics. But as far as the cases, you know, again, I think we continue to be very happy about our cases here at the health system. We have only one full hand, so 5 active cases right now.
That's amazing.
Yeah.
I'm going to start to tear up here. It's been a long year. 5
active cases, 1 in the ICU, and that patient is on the ventilator. Still 18 in that recovery period. And then Hays has 0 active infections and 7 in that recovery period. So I think it's really looking pretty good.
It is so much better. Do you feel like you can take a breath?
I do.
Yeah,
I mean, this whole week has been really nice.
It has been, and it's not over yet. We got to get everybody vaccinated. Don't get cocky, people. But this does feel good.
Yeah, I mean, we still know there are surges in other places. Brazil especially is being hard hit right now. Hopefully vaccination down there will help them. We know that there is some encouraging data about vaccination and creating or continuing to have efficacy against hospitalization and death for these variants as well, so that's encouraging.
Yeah, that was great news to see from the New England, that we saw published in the New England Journal. And then the other part we do know, though, there are still some counties in Missouri and Kansas that are experiencing an upsurge, and so we got to make sure we keep an eye on that and know that we just need to get people vaccinated because vaccination clearly works. And I think one of the things that has helped us so much is we're just not getting nursing home admissions anymore. That is great news. That is really great news. Hey, let's first see if there are questions from reporters this morning.
Good morning, Cody Holyoke from
Hey,
Channel
Cody.
9.
Cody.
Hey, today, March 11th, the day that everything changed. So I read in a number of articles. And, you know, with the Big 12 in town, we were looking back and, I mean, it was a crazy day the day before because the NBA called the games, called the season. I think Tom Hanks got the virus, NCAA, the whole 9 yards. Just curious your thought a year later, and you've touched on this a little bit in prior conversations, but where we are now compared to what we didn't know then.
Wow. Cody, that is the best question. Hawk, you lead off.
I mean, I think we have to think about what aspects are we talking about. What we know, are we talking about the science? You know, we were extremely concerned about fomitis, or going to the grocery store, ordering things. You know, how is this virus spread? I think we've learned a lot by then. Certainly we know that inanimate objects and things of that nature can be a source, but the biggest issue is that behavioral aspect of people getting together, being in close groups, multiple people. That is the main way that it's spread. And by continuing to do those good behaviors, those optimal public health behaviors of masking, decreasing, you know, not meeting in large groups, and creating a distance between you. Again, 6 feet is good, 8 feet is better, 10 feet is better. Doing things outdoors is better than doing indoors. You know, just knowing that from what we know is great. But there are so many aspects to what we know. We know now that when we have the world behind you know, a certain topic or a certain subject and puts the resources and the brain power and the money behind that, we know that we can accomplish amazing things. We have seen this in just such a short time. We've seen, you know, therapeutics We've seen research studies which showing not only antiviral drugs, but again it's the anticoagulation, the steroids, and of course the vaccination, which is going to be a huge part moving forward in the development of those things. Especially vaccination is going to help, and we saw how quickly that occurred.
Cody, I had an answer for this question as I was sitting here. My answer is completely inadequate, so I'm going to just do something else that is everybody, they don't want me to do, so close your ears. I'm going to sing for just a second. If you've seen Rent, the key song from that show is 525,600 minutes, 525,000 moments so dear. But the real focus of that song is about love. And I think as I reflect back on 525,600 minutes from the last year, there are over 500,000 people who have died. Many of them should not have died had we been better organized. But they did. But I think what's really happened is we've seen a lot of expressions of love and caring. You've seen it in healthcare workers, in the grocery store workers, in essential workers, and in people trying, and you'll hear about it in just a moment from our folks on addictions. It's about people trying to lift each other up in a time that has been like no other in modern American history for this century, surely. We've also seen things like Operation Warp Speed and really large government intervention in the crisis, which I think has helped us save lives. You've seen the world trying to work together around vaccine development. You've seen us establish new methods for telehealth. You've watched the sports world come to a halt, but the real story is you've watched a lot of the lives of people come to a halt. Sports are great, but they're the gravy. The meat and potatoes is what happens with folks every day. And I think what the pandemic has shown us is that even in our worst moments, love trumps fear, and moments of love can beat moments of hate and moments of fear and loneliness. I think that's what this year should have taught us, that when we stand together, we are much better than when we stand apart. I think that's been shown in every hospital, in every clinic, and in every grocery store, in every place in our lives where people have made a difference. Because in those 525,600 minutes, those who chose to try to work for others and chose love, I think they've made the right choice. And those are the people who made the difference. The song asks, and what about love? Yeah, and what about love? Every time you wore a mask, every time you stayed away, every time you kept your distance, I think that was about love. And I think that's what ultimately, that's what has made the difference in this year. And the folks that were hurt the most were those who didn't have people around them for that expression and that feeling of love. And I think maybe what we have learned in the last year is that when we care for each other is when we are at our best. Other questions?
As someone who had to sing that song every year in high school, I appreciate it.
That's a great song.
It is. Hopefully we continue this season of love.
Yeah.
As we move forward, I know spring break is upon us. There's been a lot of talk about letting guard down, and obviously we don't want to do that. But are there real concerns moving forward, especially with the variants starting to pick up steam?
There's always the concern, but we have seen some good data coming out that even the vaccines in the arms, the vaccines do have some real world efficacy against those variants. But again, those are the variants that we know about. We still need to get more people vaccinated to help give that overall efficacy and protection against hospitalization and death. But we do know, as we just mentioned, Brazil is having a particularly hard time now because of the variant that was identified there initially. We know that the variant in Florida has increased exponentially, but we are still not seeing the rate of hospitalization and death there. We know, new evidence has just come out of the UK showing that, yes, there is probably a higher risk of mortality with the variant that was identified there. So there is that concern, and that's why it's all the more important to be able to get these vaccine supplies and get them into the arms as soon as possible.
I would just add, you've heard us say 1,000 times, if we've even said it once, the rules of infection control travel with you wherever you go. And we also know that those rules do keep us safe. They've kept us safe in the hospital. They keep us safe now, even when there are variants out there. We see the rise that the variant from Great Britain is rapidly becoming the dominant strain in the United States. And so as those numbers increase, the story is yet the same story. That if you practice the rules of infection control, you can stay safe. And the vaccines work. And as the New England Journal of Medicine article pointed out this week, they work against all the strains, even the South African strain. So we can stay safe, and it's, it's there inside of us, folks. It's like we've said this week. It's first and goal. Don't fumble the ball here. We can do this because the vaccinations are going to work. They're going to be a game changer, and frankly, they already are. Between infection control, I think people staying indoors and sheltering, we're down to 5 patients. Now we know people are going outside. It's going to be blended a little weak by this all the rain and all the storms in the Midwest. But I think that I think we'll see in a few weeks. I'm going to guess we're going to see a few numbers pop up. I don't think we're going to see the surges like we've seen in the past because of vaccinations, especially in nursing home and those over 65. So I think we are in a much better place, and I look so darn forward to being at Kauffman Stadium. I think I said a little over, not quite a year ago now, as I said this a little bit earlier in one of our programs, that when I go to Kauffman Stadium and I sit there and we sing the national anthem, I know I'm going to be bawling like a baby, and I can't wait to do that because I so want to go watch the Kansas City Royals play baseball. I want that feeling of community again, and we can get there, but even in doing that, we've got to keep each other safe. Other questions?
Yeah, this is Lindsay from 41 Action News. Good morning, guys. I have a question that has popped up in my circle of family that I'm wondering if a lot of other people are dealing with too. If you had a loved one who ended up having to drive a great distance to get their first shot, now they are trying to get that second shot much more accessible and closer to home, and they can find appointments maybe 19 days after that first shot, or maybe a little after. How worried are you about the efficacy if it is a little before that 21-day mark or a little after?
I'm not worried at all. Hawk, how about you?
Yeah, I think certainly later is better. The FDA CDC guidance does allow for 4 days either side of that due date. But, we really do believe that later or delayed dosing is probably beneficial. It's not going to cause any harm or safety effects, but maybe beneficial as that still allows that initial prime dose to continue to develop that initial adaptive immune response. And then when you get that second dose, that booster dose, that will help continue to solidify and hopefully increase the durability or how long that immune function lasts. So I don't have too many concerns about the delay in that dose.
Yeah, I don't either. I remember when we looked at the study designs that Pfizer went with 21 days because they thought that was the shortest interval to get the good response. Yeah. So longer probably is probably not a decrement. Some people postulated you can go up to several months and still be fine. So I expect that longer, I'm with you, longer is better than shorter, but I think 4 days plus or minus on your date is just fine.
Yeah, I wouldn't speed up that day, but again, the delayed. And there's some information coming out now about getting just a dose after people who have had coronavirus or COVID-19 and looking at that. But again, the studies were directed and created to look at a 2-dose series for Moderna and Pfizer. So that's why we continue to stick with that data. As new data and information comes out, I'm sure there will be change in guidance if it's feasible.
Other questions?
So a radio reporter from Southwest Kansas is asking, what do you say to 25 to 30-year-old employees who do not want to get the shot?
Yeah, so I think the key message to people who don't want to get the shot is that it's not only about you. And I think that's one of the keys about vaccination. What we're really doing is trying to keep each other safe. And at age 25 to 30, you may not do badly with coronavirus, although you might. Your odds are so much worse with coronavirus than they are with influenza. But you will still carry that virus to others. And remember that unless we get 70 to 80% of the country vaccinated, we're going to have a harder time really getting rid or pushing coronavirus down to hopefully getting rid of it, hopefully truly ending the pandemic. So the more people, because you could still get it and spread it, and there still is widespread community acquiring of COVID-19. And so I think the most important message is, A, it really can get you. B, you can get you both short and long term, because we're seeing the rise of symptoms 3 to 6 months after infection, which are really serious. And then number 3, remember that you will have those around you, some of whom may not even get a great immune response from the vaccination, or who may not have gotten the vaccination either, who can spread the coronavirus, and you can give it to one to the next. So don't forget that vaccination is not only about you, Hawk.
Yeah, I would agree. I mean, I think before we said we were really conscientious about people who are vaccine hesitant because of safety and efficacy concerns. I would say those concerns are really melting away. There are no real major concerns about safety or efficacy for these vaccines. So that vaccine hesitancy argument is really being diluted and diminished on a daily basis. So I would go get it if you're vaccine hesitant because of that reason. The other thing is, you have just talked about the UK variant. We have shown, and it has been shown, that it does offer probably an increased risk of mortality or death. We know that if you are young, you probably have a lower risk in general, but it can happen to anybody despite a lower risk. You could be one that it could happen to. So, and we know that these vaccines do offer protection against that as well. So I think the main gist of that is just, get the vaccine, don't throw away your shot, especially because you don't want to spread it to other loved ones who may be more vulnerable.
Other questions? All right. Hey, we're going to get into this discussion now about addictions and about some really new special drugs that are really impressive, and we're going to talk about that. But first, we have an important video to show you.
I blew through a lot of money and my savings, and I wasn't a good employee. I wasn't a good boyfriend. I wasn't a good, anything really.
Nearly 20 years of opioid addiction was taking its toll on 38-year-old Clint Adams. He became addicted after breaking his ankle when he was 19. Prescribed medication eventually led him down a dark path.
You can buy these laced pills that are just terrible, and they're based with fentanyl, I believe. I don't really know. I was taking a risk just doing some street drug, and I would crush them and snort them is where it got in the last few years.
Stints in rehab and medication helped some, but not long term.
At first, I think I was doing it just to please my family and my girlfriend, and I'd take it for a little bit, and then I'd stop taking it when I decided I wanted to get high, or that I thought I had control over my addiction. And it was just a cycle like that for years and years and years.
But a new option came in the form of a new medication and the way it's given to patients.
People who don't have time to go to the doctor every week or something like that, or professionals, it's a better option, I think.
It's called Sublocade, and Clint was the first patient to receive it at the University of Kansas Addiction Treatment Center. Sublocade continuously releases medicine into the body for a month at sustained levels without the daily ups and downs.
When you get to a certain point with opioids, all you do is you need to take them to not be sick and to be able to function in life. So it's more of a need than a want.
Now, on his second dose, Clint says he's starting to round the corner.
If you're a drug addict, like to where I was, you lie. Your whole life is built upon lies.
But not now. Clint is a proud 90 days sober and takes it one day at a time.
And I look forward to just gaining my family and my girlfriend and my friends' trust back. But yeah, it's working real well for me.
Dr. Sethi, Clint is your patient.
Yes, he is.
How is he doing?
I think he's doing phenomenal. This is the best improvement that we have seen in him. I've had Clint for almost 2 years in my practice, and we have had him on the oral Suboxone form, the buprenorphine form, and he would have multiple relapses on opiates. But since we've started this, he's a different man. We have a better quality of life. His wellness outcomes are better. His social things at home are better. So he's doing much, much better.
So Sublocade is the drug. It was formerly, I think, a pill, and now it's a monthly injection. How does it work? Tell us about it.
So the pill form is called Suboxone. It's taken under the tongue, sublingually, and it's taken multiple times a day. Sublocade, on the other hand, is an injection that's given in the tummy area, and it works, slowly releases from that area for up to a month. And so it works like that.
And so how does it work? What does it do to help you stop addiction in its tracks?
So it goes and binds to the opiate receptors and keeps them bound. It's a partial agonist at the receptor, which means if it's bound to the receptor, it's partially activating that receptor, so you're getting some effect. But if you take an opiate on top of it, the opiate is not going to be effective. And if you have a constant level of that medication in your system and you take an opiate, you're not going to get a high or not going to get a craving or a withdrawal. So that tends to deter you from using the medication or the drug.
Well, that's fantastic. I love that. I mean, so in other words, Sublocade binds to these receptors that the opioids would normally bind to give you a high, but it doesn't quite give you a high. Is that right?
Does not give you a high.
That's awesome. And then if you take the opioids, it doesn't do you any good. So if you stay on the Sublocade, you're blocking the entire effect of the opioids, and therefore you don't have the same craving.
Right.
So how is it you don't have the craving? Because I would think, gosh, I still want to take more and more opioids to try to. How do you not have the craving? Does the Sublocade block the craving too?
It does block the craving. So
Wow.
the whole part about craving is that if those receptors are unoccupied, they're kind of making you want to use, and that leads to that sense of craving. If those receptors are now occupied with this medication, they don't feel the sense of taking something because there is some activity at that receptor, and that prevents craving from happening.
That's impressive. And you say it's injected in the stomach, just so people think that they should be afraid of it. Those stomach injections are becoming pretty standard in a lot of different therapies. I have a really high cholesterol, and I take the drug called Praluent that I inject, once every 2 weeks into right there in my belly. And you know what? No problem. It's actually kind of easier than it is to take a pill every day. I kind of like it. So go ahead.
I was just going to say, is there any monitoring of the Sublocade drug levels throughout the month or at the end of the month or anything like that?
So before we start the injection, we tend to do liver levels or liver function tests on the patient. But then once the patient comes into the clinic, he is given the injection and then monitored for a couple of hours. And then we just give them injection every month if they don't develop any side effects to it.
Wow. And so do you still use the pill form, the Suboxone, or do you only use the injection now?
We are still using the pill form. There will be patients who will better like the pill form, and there will be patients who would like the Sublocade. The pill form is better for some patients who might not meet criteria for being on Sublocade. So, for example, if they have a liver which is not working very well, or they have some kind of respiratory depression or breathing problems, or a cardiac arrhythmia or a heart problem, then those might not be good candidates for Sublocade injection and might want to stay on the Suboxone pill.
This Sublocade sounds like a big deal. So who is the right candidate for it?
So typically, first of all, they have to be had a problem with opiates. So somebody who's had a diagnosis of an opiate addiction. And then any person, male or female, so man or woman, 18 to 65 years of age. And then if they have a desire to be on that injection, people who desire to be on that injection would be somebody who's working, does not want to have a controlled substance in their pockets all the time, worried about diversion, worried about what would happen if somebody finds out at work that I'm on this medication, would be like the best candidates for this injection. They'd come in once a month, get the injection, and they don't have to worry about anything.
Yeah, that's impressive. So do you still have room in your capacity in your clinic for seeing more folks?
Absolutely.
Yeah.
We have Suboxone providers in the clinic who are there. Our nurses are all trained about this. And we are working very closely with the pharmacy, so we are definitely looking to expand.
Well, Cyndi, you're the one who is giving these injections. Tell us a little bit about the process. Is it painful, or how's it go?
Sure. So the patient would come into the clinic, and they would be laying down on the examining table. The medication, as Dr. Sethi mentioned, is injected into the stomach area under the skin. It's injected as a liquid, and then it changes to a solid form called a depot, and that depot creates a little bump. That bump will stay in the abdomen or the stomach for about a month, and then it gradually diminishes, gets smaller. So it's a fairly easy process. It's somewhat similar to insulin injection.
Is it painful, or does it itch? Does it hurt? What are the side effects?
So it can be somewhat painful as the medication is being injected into the stomach. However, we can alleviate some of that discomfort by icing the area before and after, and also using some numbing cream before.
Yeah, that sounds like a really a great thing. And I take it people can't take the drug and give it to themselves at home. Talk to us about why it has to be done in the clinic.
That's correct, because it would be very dangerous for the patient to take it at home. In fact, the Kansas University Health System has undergone an actual training called the REMS program, which is an FDA program that mitigates risk for the patient. So only health systems can actually distribute the medication.
Is that partly because it would have like street value or something like that? We're worried about illicit activity around it?
Yes, plus some patients may want to inject intravenously. That could be very, very dangerous.
Yeah, so we know that addictions are tough, and people make sometimes not the best choices, even though they may try to be good folks, but it's hard. I mean, addiction is just hard, and I think that it's really important to do this in a safe environment in which the patients can stay safe just from the injection itself, but also from any behaviors that addiction could lead them to. Thoughts?
Yes, yeah, for sure. I know we were talking about perhaps some of the side effects of the Sublocade, which the most common and are fairly minimal would be constipation, which is pretty frequent even with any opioid use, headaches, nausea, vomiting, pain around the injection site, itching around the injection site. Typically that would only occur, for the first day or so, if it did occur.
And does this really eliminate the craving in your experience?
It does. It definitely eliminates the rewarding or the pleasant effects that patients typically get with opiates. So
that's really impressive. I mean, what a revolutionary trial. I mean, you guys have to have looked at this and thought, holy cow, this is like the best thing here. So Dr. Manzardo, you have some slides I think you wanted to present to us around this topic.
Well, and this is not specifically pertaining to Sublocade. Early on in the pandemic and during the shutdown period, Dr. Sethi approached me with some concerns about risk factors related to anxiety and the pressures associated with the economic shutdown and the COVID outbreak, and started a surveillance program within the clinic to kind of monitor individuals and some of the concerns that they may have, and to try and have the clinic staff get alerted if people needed extra resources. And so we did some surveys, and initially we had expected that patients who were older or had high risk of, comorbid health conditions that might put them at risk of having some kind of adverse reaction to COVID, that they might have, more anxiety or withdrawal risk. But it turned out actually it was kind of surprising that it wasn't the older patients that were having anxiety and craving and withdrawal. It was the younger patients, and that was tied more to their concerns about financial insecurities. And so we found, if you're looking at the figure that you have up, looking at our spring examination, we found that about 40% of the people surveyed reported that they were having concerns about their financial ability to support themselves during the shutdown. About 40% were worried that they would lose their job. Now, when we surveyed them again in the summertime, you could see that there were, a good 40% of people that did actually have financial problems. Only about 25% lost their job. If you go to the next slide, that's talking about some of the access to food. I mean, in the spring survey, we asked people if they would have access to food and shelter and housing, and we found that 90% of them at the spring said, yeah, sure, we have enough food to get through the shutdown. And then when we polled them again in the summer, we had 30% who reported having difficulty during this time feeding their family, as well as about 20% going to use food banks. And so there was a lot of stress put on individuals, and I think some of this tended to target women more. We found that in the spring survey that females were more concerned about the financial stressors than males. Interestingly enough, though, when we surveyed them again in the summer, there really weren't a lot of gender differences in the actual impact. But women were just more anxious about it. Perhaps the men should have been more anxious about it. But, there was a lot of social pressure on them, and it really was reflected in the younger people and not the older people.
The pandemic has just affected us in so many ways, and I think you hear it even in your voice as you look through this. This happened about the same time as physicians were being asked, hey, don't prescribe opioids so much. And prior to that, we were told, give a lot of opioids. Nobody should ever have any pain. And I remember when I heard that back then, I was like, no, that is just wrong, right? Yeah. You just can't get rid of all pain in life here. But what's been impact of the pandemic, plus people trying to write fewer opioid prescriptions? Well, what's been the impact of that together?
As far as on the patient population.
Yeah, exactly.
The data clearly shows, I think the CDC reports for anxiety and depression, you're seeing a tripling to a quadrupling of anxiety and depression in just general surveys. They've had a lot of increases of opioid overdoses. You could see when all ER visits and ambulance runs were decreasing, there was an increase in opioid overdose. We saw even, I think, at the state of Kansas, we probably saw almost a doubling in the rates of overdose deaths in April and May last year after the shutdown.
Yeah, such important information, really. So is Sublocade covered by insurance?
I think Dr. Sethi will have to answer that.
Dr. Sethi?
Sorry. Yes. So a lot of insurances do cover it, and we have actually placed it on multiple patients. Once we place the medication, it goes through pharmacy. They do what is called a benefits investigation for us, and it tells us what the copay for the patient will be. And till now, I can say almost out of, if I've done 8 prescriptions, almost about 7 have been covered. There are a few insurances that don't cover it, but we actually have a grant from the state of Kansas where for the uninsured and the underinsured patients who have opioid dependence, we can actually give them the medication for free.
Oh, that is great. That grant's a big deal.
Yeah, I mean, it sounds cheap for the insurance companies if they provide it, especially like you talked about with our first patient. He had multiple relapses, and if you can protect against that and worse outcomes with relapses, I think that is that's a financial benefit and a health benefit for the patient and their family as well.
Absolutely.
So one of the questions I think people might be wondering is how they get in touch with the clinic.
So they can call our clinic. We have a number called 913-588-6493. That's one way of coming to us. Or they can call the main hospital and ask for the addiction clinic. And we are also named as Addiction Treatment Center or the Chemical Dependency Program. So they can ask for any of those. And then even if they get a voicemail, if they leave a message within 24 hours, we tend to call them. And we tend to do all the screening over the phone, where we ask them what are they looking for, what is the long-term goal, what all drugs are involved, what all help they need from us. And we have all that information, and then they get an immediate appointment within 1 to 2 weeks with one of our providers.
Yeah, that's outstanding. And Dr. Manzardo, I noticed that I have a prompt here that you've written a grant for the clinic. Is that grant there to offer help for folks who don't have insurance or can't get the drug?
Well, I think Dr. Sethi and I have put out some applications for different support approaches, either to support further education for addictions medicine or for funding support for different services to provide access to care usually.
as you look at this drug, this has to feel revolutionary to you. You're a frontline person. You're talking to these patients all the time. Has this felt like one of the best things you've seen?
Yes, definitely. Very, very exciting because the patient does not have to come into the clinic very often. They know that they're going to be stable throughout the month and they can get on with their lives.
Yeah, that is so impactful, isn't it? Mm-hmm. Well, Jess, let's see what questions we have from the community today.
Isaac wants to know if there are any known effects of opioids on COVID or the vaccine.
All right, COVID or the vaccine. Hawk, I don't know of that. Do you, Sethi?
I would actually see if you have heard of it. We haven't heard of it.
Yeah, I mean, I think for COVID disease and severity, I wouldn't, other than if you take too much, like you talked about, if you have a respiratory depression or some sort of issue like that. As far as the vaccine goes, I would say no, there's no probably mechanism there to reduce the immune response from the vaccine.
Amanda lost her sister to breast cancer and her brother to drug overdose during COVID. Are there any bigger statewide or national initiatives in the works right now to help reach more people with drug addiction? COVID made this problem so much worse. How do we play catch up?
First of all, our heart goes out to you. That is, again, this pandemic has had unmeasurable loss. But thoughts about that, team?
So I can start with our addiction treatment center and
Please.
say we have been doing Zoom appointments or telehealth appointments for last 1 year and are still continuing to do that. Even if the patient is located at a place which is far off from us, we can still start or initiate any kind of treatment. More and more studies have shown that actually if you initiate some kind of medication for opioid use disorder early on and then get into some kind of long-term treatment programs, your overall outcomes actually improve. So I would highly recommend them to contact us in the Addiction Treatment Center, and then we can provide them referrals once they're there to other long-term facilities or 30-day programs or IOPs that are out there in the community.
Team, anything that anybody would say any different? Cyndi, Dr. Manzardo?
Well, I know that NIDA has a major interest in obviously alleviating the opioid crisis, and this is a major focus of research and clinical access. You know, they've been expanding the use of drugs that reverse the effects of opioids and try to get those into hands of, first responders so that they can help. If somebody is unconscious, they can revive them. And so there's a major initiative through the federal government in order to address this crisis.
Are there other addiction centers around that have Sublocade available? I suspect we're not the only one.
I know that there are 1 or 2 other private clinics that do Sublocade. I have asked a couple of bigger addiction centers, and they still don't have Sublocade. So we are kind of one of the early ons that have started. This drug was approved in 2017, but to go through the REMS program, it has taken us 2 years to get everything set in place. So there are fewer centers, but I hope going forward that more of this drug is available to other places
Well, it just
as well.
sounds so important
Yeah.
because there's so many people who struggle with addiction.
Payree wants to know, does Sublocade work the same for men and women with hormones and such?
I would say probably yes. It is typically given in the abdomen area as we talked about it, and it's slowly released from there. If we do the oral or the sublingual form of Sublocade, which is Suboxone, it has had equal outcomes in both men and women. So our hope and expectation is that Sublocade will also have similar results in both men and women, and that hormones should not have an effect on it.
And Emily wants to know, how is Sublocade different from Vivitrol?
Sure. So we also have a Vivitrol program in our addiction treatment center. So if this was, and I'm going to say it in very crude words, but if this was the opioid receptor, and this is where the opiates would sit and bind and produce the effect like euphoria or anything that you're using it for, Sublocade also sits on this receptor, but it partially activates the receptor, which means it partially produces some positive effect at the receptor. On the other hand, Vivitrol, which is also an injection, it's a blocker of this receptor. So if you are having cravings or if you have been actively using opioids, then you might be a better candidate for Sublocade initially. If you have been in remission, which means you've not used opiate for a long period of time, but you're worried that you might relapse on other drugs or on opiates, then you might be a better candidate for Vivitrol injections.
Vaccine question. Linda wants to know, are the 2 doses of the vaccine identical or are they different formulas?
Okay, they're identical, right?
They are identical. Yeah, for Pfizer, I believe it's 30 micrograms per dose, and for Moderna, I believe it's 100 micrograms per dose. But they are exactly the same because we know that I think in the Russian adenovirus vector vaccine, they use 2 separate adenoviruses that are different. But really, for the 2 doses for Moderna and Pfizer, they are the same dose.
Joanne wants to know, I have not heard how long the vaccine lasts after you complete your full 2 doses. I've heard it's only 90 days. Is that true?
I think we've said it's 90 days we're sure you have protection because there are still ongoing study. But I also know that now this data is about 6 weeks old, I think, that it was in the New England Journal where they found high antibody titers as much as 8 months after an injection in some of the initial study subjects. Hawk, what are you hearing?
I mean, overall, we don't know the full answer to that question. We believe it's definitely more than 90 days. And that's the important part of getting that second dose, is to increase that durability or how long that immune response lasts. So we are hoping, 6, 9, 12 months. And then, like we've said before, most people expect some sort of booster at a year, just like an influenza vaccine. Will it be before then? I think that depends on how the variants are going and how quickly, say, Moderna and Pfizer can pivot their vaccine to match any new variants or things or surprises that may occur as well. But I think most of us are really expecting and hoping that it lasts for that 9 to 12 month range.
Do you know if parents of high-risk children can get the vaccine and get on the list, even though it's not necessarily their phase?
Yeah, no, that hasn't changed yet. And here's what I think we just have to watch for. You're watching states that have gotten through 65 are starting to just blend the next few phases because it's really hard to try and separate it out. I think that's going to happen. I'm going to bet that that's going to happen in Kansas and Missouri, but we're not through the 65-year-olds yet. And so once we do, I think the vaccine supply is going to ramp up dramatically in April and then May. So for the next few weeks, things are not going to change. It just is going to be how it is, and there's no special consideration given for situations like that, even though it feels compelling. That's not. The rules are 65 and above because that's who has the highest mortality rate. And so if you get COVID-19. But I think what we'll find is as we get more vaccine available and production is ramped up, I think it's just going to open up, and then it's just going to be how fast can you get the vaccine where. And so, we heard this morning, I think the supply in Kansas is supposed to quadruple in the next few weeks. Well, that's a game changer, right? And it may go higher than that. And so as it does that, if we got 250,000 doses a week and Kansas has 4 or 5 million people, we'll get through everybody in 8 weeks. That's a really big deal. And then it's just how can we get people vaccinated? Where are you going to sign up? I mean, I think the story is going to turn on a dime in a few more weeks about how you can get vaccine.
Yeah, that's what we expect. And we have to remember what Secretary Norman said as well. We have everything that's allocated to the local health departments, but there's a separate allocation from the federal government to the local pharmacies, and that includes the major chains, but also those small independent pharmacies that he talked about. So there will be 2 different mechanisms there, hopefully overall to increase supply, and people can just schedule a time very easily and walk in and plan it out so they have 1 or 2 days later if they need to rest. But I think it will be a game changer.
Yeah, and it's coming, and I think you'll see it. I think you'll see it in multiple places. I think the pharmacies will play a major role throughout the country. I think healthcare systems. I think eventually clinics are, especially around the J&J vaccine. Hopefully, in the not so distant future, you'll be able to get it in primary care clinics. We don't know that yet, but I think one of the great things about the J&J vaccine is its stability at room temperature. And I also think that we'll see it continuing in mass vaccination centers, health departments, and many other ways, FQHCs. There will be so many ways to get a vaccine, and those days are coming. And I know it's hard to be patient for a few more weeks when you've had to be patient for over a year. But remember that until then, We've proven over and over again, as we prove it every day in this hospital with the many, many staff who have worked directly with the most infectious patients who actively have COVID-19, it doesn't transmit if you follow infection control procedures, because the number of people who we've had that happen with is vanishingly small. You can stay safe if you follow the rules.
Jody wants to know, why does it feel like we are so far behind in getting people vaccinated than other states? Or is it just because we live here and it feels that way?
That's a great question, Jody, and I don't have all the information to answer that question. I think it's probably a combination of factors. I think, first of all, Kansas is, you see the data out there that says we're behind. The reality is, as an example, we have 7,000 shots for KU that the state doesn't know we've given, but we've given. And the problem is just that was earlier this week, the load up into the data management system has just got caught in some loop, and we thought we submitted it. We did submit it, but the state hadn't registered that yet. That is just a technological error, and the reality is we've given most of the shots out in Kansas. I don't think there's a lot of shots sitting on shelves, so I'm not concerned about that. You know, if you believe that everybody's gotten the amount they were supposed to based upon their population, you'd say that we've all allocated it out. We do think there is some vaccine that has gone unused in some of the health departments. I know the state's trying to cull that back and give it back to the areas that still need it the most. I think at the end of the day, what we're going to find out when we look back on this is that some states took a different approach to vaccination than other states, and I think that's what we're going to find out that has made the difference, both in how they did it, but also in who they said, because the CDC may have said those over 65, but some states opened it up more rapidly, and they tended to just give the shots as fast as they could. They didn't wait to get everybody who's over 65. They just gave it out to whomever was coming in. So there's a lot of different factors that are in play here. I think what you're going to find out is that at the end, when we look back on it, things are much more similar than they are different, but that doesn't feel like that right now. If you're the person who needs and wants that vaccine and you see others getting it and you don't, that makes you feel like the thing is unjust. What I would remind us all is that COVID-19 doesn't care about just. It just cares about getting into you. And so until you get that vaccination, stay safe. Follow the rules. Last question.
This viewer wants to know if we have the luxury of choice when it comes to the vaccine. Is there a better choice for someone who is a childhood leukemia survivor, or should you just get what you get?
Hawk?
Yeah, I mean, if you have choice, again, I don't think there's any better one right now per the data as far as vaccine efficacy and keeping you from severe disease, hospitalization, and death. So I would get whichever one you can get. We've heard this brought up before about if you have moral objections to one or the other, and we know that the U.S. Conference of Catholic Bishops has weighed in on Johnson & Johnson versus Moderna and Pfizer, so certainly there. But if you are given a choice, really, I think it's mostly going to be based on whatever moral objections you have, really not on scientific or medical objections from the best data that we have, because they are both the mRNA vaccines and the adenovirus vector vaccine from Johnson & Johnson, both extremely efficient and safe and keeping you out of the hospital and keeping you from that severe critical illness and death, but also reducing your risk of having asymptomatic disease, so having disease with no symptoms at all. So therefore, we also think you can decrease the amount of spread by getting either one of those.
So really the best vaccine you can get is the one
that you can get.
Is the one that you can get. All right. Hey, tomorrow, Dr. David Wild, our Vice President for Performance Improvement, often a frequent visitor to this program, will be here. And Amanda Cackler will not be here tomorrow, but I think that'll be a great program. So let's turn to our guests for final thoughts. Dr. Manzardo, I'm going to start with you.
Well, I mean, I think it's been a long journey for everybody, and certainly it's been very stressful for many people. I'm one of the lucky people who've been able to work from home, and my hat's off to all of my clinical colleagues who've been out there really towing the line and making sure that our patients were cared for. So I think that it really is a heroic effort, and my hat's off to all of you.
Cyndi Brooks, final thoughts.
We have help for folks that need it, and we're very, very eager to assist. So please call us.
Thank you. Thanks to you both. Dr. Roopa Sethi, Final thoughts.
I'm going to echo what Cyndi said. We are here and we are here for you. Please call us if you have any questions. We can at least answer your questions and help provide you guys support of any kind that we can.
Yeah, I mean, I have to piggyback on that. We know addiction of any kind can be harmful and detrimental, especially substance abuse addiction, including alcohol, opioids, anything of that nature. So we have people who are willing to help. Please call and please get an appointment. And then pivoting back towards the virus and the infections, you know, we are definitely very happy and optimistic how things are going, but we know that we are coming up on nice weather, people wanting to get together for basketball or other family get-togethers, parties coming up. Just please continue to do the right things. Be healthy. Don't gather in large groups. Wear your mask. Keep the numbers in the Kansas City area low, and we can all get through this together because we are getting closer to that light at the end of the tunnel, and it's looking pretty good. Just hold on a little bit longer so we can get more of the general population vaccinated.
We've said it before, faith, hope, science. Opioid epidemic, Sublocade. What a great outcome for science. And the end of this pandemic, vaccination, infection control, another outcome of science with amazing vaccines. Faith, hope, science. You know, I tried to sing Seasons of Love. That was terrible. I'm sorry about that. But, you know, it's an irony a bit that Jonathan Larson, who wrote Rent, passed away on the morning of the opening on Broadway from an aneurysm. And when you reflect on what it's been like for the last year and all the death that has occurred, I'm reminded of other words in that song. How do you measure a year? In daylights, in sunsets, in midnights, in cups of coffee, in inches, in miles, in laughter, in strife? Wow, has that been this year or what? And then he goes on to ask, how about love? How do you measure in love? I think that's the answer. In truths that she learned, or in times that he cried, in bridges he burned, or the way that she died. It's time now to sing out that the story never ends. Let's celebrate and remember a year in a life of friends. That has been the year of this pandemic. But what about love? Faith, hope, science, and love. That is how you answer a pandemic. We'll see you tomorrow.